4 CCOs in southwestern Oregon are collaborating to support our communities as we work towards safer and more effective treatment of chronic pain. We have created this video to offer tools and training to those of you who may be serving patients that are understandably fearful, confused, or angry about these policy changes. We have become aware of the terrible consequences related to overuse of opioids. This slide graphically illustrates how this issue is affecting U.S. mortality data. You can see that other countries have seen decreasing trends in mortality over the last 20 years, yet one specific U.S. population is on the rise. When you look more closely at the cause of death, you see a sharp increase in deaths related to poisoning. This rate now exceeds deaths related to preventable accidents and chronic diseases like diabetes and cancer. The United States consumes 80% of the world's supply of opioids, yet we are only 4.6% of the total population. Clearly, action is needed. In this video, we will show 3 perspectives on this problem. First, we have Dr. Jim Shames, who will provide some context for this work, how we got here, as well as where we need to move going forward.
So let's talk about pain, because it's really a component of the human condition. We all have pain. We're born into pain. We often die in pain. And certainly as we get older, we have pain as part of our life. For starters, acute pain is really quite different than chronic pain. When you have an injury, you break a bone, you have surgery, you have a tooth pulled, you have a baby, there is tissue damage which stimulates pain. And the goal of our treatment is to assuage the pain on a short-term basis, get people back to functioning, and let the body heal up on its own. Chronic pain occurs when the healing has already occurred. And there is, of course, some tissue components, but how we feel about the pain, the trauma we've had in our childhood. If we're depressed, if we're anxious, we bring a lot of emotions to that pain, and we can amplify the pain. We can make that pain more significant depending on how we feel. And I think that's really important for us to understand. We have in our bodies natural opioids, so to speak, and they go up and down throughout the day, and they're responsible for our pleasurable response to many things. And we have the ability to overlook certain aches and pains so we can get things done, etc. And those are very important parts of our daily living. When you take an opioid, something from outside your body on a regular basis, you overpower that natural system. And that part of your body just kind of goes to sleep. It says, okay, you don't need me anymore. I'm going to shut off. And so now you are fully dependent on external substances to relieve all sorts of pain, even emotional pain. When you stop, after you've done that for a while, you have withdrawal. And it can be extremely uncomfortable. You have no protective mechanisms. You don't have those natural opioids anymore. And your body can be screaming in pain. You can have all sorts of symptoms. And that's very hard for people to tolerate. And it can go on for days to weeks to months to some extent. And that's what physical dependence is. And everybody will become physically dependent if they take enough opioids for a long enough period of time. So the real tragedy here is that although opioids can be so effective when you're in a great deal of pain acutely, the effect wears off. We become tolerant to the benefits of opioids. And so over time, opioids perhaps have about a 30%, for most people, about a 30% effectiveness of pain treatment. And that's not really very much. Good quality sleep, adequate exercise, mindfulness, CBT, those things actually, for most people, are more effective than opioids in relieving pain. So opioids have significant side effects, they have definite risks, and the benefits are modest at best. I think it's very easy to get confused between the concepts of physical dependence and addiction. So physical dependence is the withdrawal that people will experience after they've been on a substance for a while and it's been removed. And some substances will do that and some won't. You could take amoxicillin for 30 days and stop it and you'll have no withdrawal reaction. But if you take opioids for 30 days, you're going to get very sick when you stop. And that's universal, and that will happen to everybody. Some people, either due to genetic predisposition or exposure to a lot of the drug or societal factors or all three, are at risk of losing control of the medications. Not only will they experience withdrawal, but they will find themselves pursuing the drug, obsessing about the drug, doing things to get the drug they would not otherwise do. And once you've lost that control and given yourself up to the medication, you're exhibiting signs of addiction. And some people say as many as 25% of individuals on chronic opioids will become addicted. And I think it's important for us to realize this could happen to everyone. So one of the questions is, how did we get here? And I think it's helpful to go back in time and realize that 30, 40 years ago, we didn't really have the same concept of chronic pain. We certainly knew opioids were useful, and hopefully we used them appropriately for people that had injuries and appropriately for people who were dying, who had end-of-life issues, who had ongoing pain due to cancer, for example. But we weren't using opioids for back pain and headache pain and shoulder pain. And a cultural shift occurred. Some of it, I think, was throughout the culture in general, where we came to believe that there was going to be a pill that would solve all of our problems. We did direct advertising on television for pharmaceuticals. We're one of the very few countries that does that. And I think that we've created a culture where, as I said, people expect that if something hurts, there's going to be something safe they can take that's going to help take the pain away. Purdue Pharmaceuticals produced oxycodone, became one of the most popular selling drugs in the world, and we were led to believe that this drug was safe, wouldn't cause addiction, that if people complained of pain, it's because they weren't taking enough medication. And that turned out not to be true all around. So I want to acknowledge that the people at the front desk, the people who answers the phones, the medical assistants, the nursing staff, the ones who probably interface with patients much more than the prescribers do, that you all have a difficult but very important job, and that patients respect you, they listen to you. You know, you in many ways are an extension of the providers in the exam room. I think it's really important for you to understand the same message that the prescribers are learning as well around the safety of opioids, some of the dangers of opioids, and techniques to help people go from opioid dependency to being independent of those medicines and learning to manage their medications on their own.
Knowing that frontline staff want to provide excellent service when confronted with potentially difficult conversations, the next section offers some suggestions and tools around how to navigate this challenge. We talked to CCO customer service representatives and asked them to tell us about their most challenging situations. We use that information in the creation of this content. Though this section is framed from a CCO perspective, conversations like these happen across the community. The communication tools demonstrated in this section can be translated for use in other settings, like medical clinics or community service organizations.
So many of you may have questions about what's happening in the next few months around what we're calling the 90 MED shift. And Kelsey and I are going to be having a conversation based on our experience working in a clinic with people who were often being asked to taper down or off of their opioid medication.
So Laura, in simple terms, what does the 90 MED shift mean?
So basically, what's going to happen is that any patient who is currently being covered by a coordinated care organization Medicaid plan is going to be receiving a letter, and they're going to be contacted by their doctor's office, and they're going to be asked to reduce their morphine equivalency dose of prescription opioids. What's happening is that we have 4 coordinated care organizations, and we're all going to be working together to roll this forward so that all of our patients and all of our members are receiving the same message. So Kelsey, can you tell me what types of non-opioid treatment options are available for our members and patients?
Well, this varies from CCO to CCO. There is a tool called the Benefit Crosswalk Opiate Alternatives, which highlights all the options. This tool is available to CCOs and providers. So Laura, when someone calls and they're scared or upset about the change, how can I best help them?
So Kelsey, I think the most important thing to do is to validate a person's experience of what they're going through. I think we need to recognize that for many of our patients and members out there that have been using prescription opioids for a long time or have come to rely on them very deeply, that this can be a very scary change. So the first thing would be to validate their experience of whatever emotion they're having. Maybe they're afraid, maybe they're angry, concerned, and then to really ask them, how could you support them? What is it exactly that they are needing, or what is the question that they have for you?
So Laura, how do I validate them when the member is expressing blame towards the CCO or their provider?
What's important to remember is that you do not need to apologize for this change that's happening. It is about safety, and ultimately it is in patients' best interest to be reducing on these medications. So again, you can validate a patient's experience of whatever emotion they're having without having to apologize for the change that's happening. So Kelsey, what about somebody who's calling in and clearly they're in withdrawal or they're going through some kind of a detox? What would you suggest of how you might handle somebody in that situation?
Well, the approach is the same, to validate their experience and express your concern, knowing that with this shift, it's not uncommon that patients are going to be experiencing some uncomfortable symptoms. What you'll want to do is be sure to take their concerns and notify the appropriate clinical staff. You may need to connect them with local resources like their medical provider, a clinical pharmacist, or even a helpline.
So Kelsey, how would you recommend that somebody compassionately end a phone call with somebody when somebody is clearly upset and maybe going on and on?
Well, continue to validate the member's experience while still setting limits.
Let's say I'm the person on the other end and I'm very upset and I'm going on and on. What would you say? How would that look if you were just going to end the call? And wouldn't that be mean?
I would probably say something like, Laura, I hear that this is really challenging and I want to help you. Right now, the best thing I can do is end this phone call so that I can notify your provider of what's going on and someone will follow up with you as soon as possible.
And what if they wouldn't stop talking? What would you do then?
Then again, it's important to remember that limit that you're setting and go ahead and hang up the phone and make sure to follow up with your supervisor.
So Kelsey, we talk a lot about validating. And can you tell me a little bit about, like, what does that really mean? What does that look like in the real world?
Yeah, great question, Laura. It might be best to actually practice expressing that validation. Why don't we go ahead and do a role play right now where you pretend to take on the role of the patient and I'll be the person receiving your phone call.
Okay. Kelsey, I just got this letter in the mail and I don't know what to do. I'm in so much pain, and this letter is saying that I'm going to have to reduce my pain medication, and I can't live without my pain medication. So I need you to help me. I need you to do something. Can you do something for me? Because I'm not going to be able to live without it.
Yeah, Laura, I would really like to help you. It sounds like that letter has caused some confusion and maybe even some fear for you about what might happen around your medications.
Yeah, I'm very afraid.
Yeah, absolutely. Now, have you contacted your primary care provider?
Well, no, because I thought I would just call you first because I can't ever get through to them, and I was certain it was a mistake, so I thought I would just call you first because I'm sure that you'll be able to help me.
Oh, of course, Laura. I'm glad that you called me, and I would love to help you. One of the things that we'd like you to do is contact your primary care provider directly. They're really going to be able to help you make more sense of this and understand how this is going to look for you.
Well, I don't know. I'm in a lot of pain.
Yeah, I hear it's probably very painful. Is there anything specific that I can help you with?
Well, I guess I wonder if I call my doctor's office and I can't get a hold of him, would it be okay if I called you back?
Absolutely. If you have trouble reaching your doctor's office, please give me a call so that I can help you with that.
Thank you.
So Laura, where can I go to read and learn more about this topic?
Well, all of the CCOs will have information on their website in this area. Also, the Center for Disease Control has an amazing website with some really great tools if you want to learn about what's happening across the nation. Locally, we have the OregonPainGuidance.org website, which is also very informative, and you can learn a lot more about what's happening locally.
Finally, we offer the perspective of an individual who has lived with chronic pain, who will share the difficulty she experienced getting off medications that were actually hurting more than helping, and how much the compassion and hope offered by patient service representatives and medical support staff meant to her.
My name is Michelle Maricos, and I have lived with chronic pain since 2003. I was on high-dose opioid medication and was able to taper off that medication. And now I live my life with chronic pain, but without medication. Just living with the chronic pain is hard, but then you have this other monster of being taken over by these medications, and you have no control over how you feel or how you interact with people. You're angry all the time. There's so many emotions that go along with living with chronic pain. Anger, sadness, fear. Living without your medication and not knowing what to do and not knowing how bad your pain is going to get is very scary. So what you say to people living with chronic pain is a direction to lead them to hope, education, and support. Anything that you can say to make this process easier is going to be helpful. That you're going to be part of the solution in this process. You're that person that's not part of the medical community, that's bridging the gap to help these people. Giving all of the alternatives of the mindfulness, the meditation, any kind of alternatives that are covered by the program would be really great. You're the most important piece of the link at some point in these people's conversation, in these people's lives, in these people's days, that if they're having a bad day and they call you and they get off the phone with you and feel a little bit better, you've made a huge impact. Going through an actual taper and getting to a part of your life of getting your personality back, that was a turning point of starting to feel like myself again, starting to laugh again, starting to be able to think clearly again, and being able to joke and wanting to be around people. That was a good turning point also. I feel good. I feel as though I can accomplish more things. I feel as though I can get back to a normal life. I will always live with chronic pain, and I will always have to be conscious of that, but being able to have my mind, my personality, and some of my spirit back is wonderful.